I hope you can see my screen. Can you see my screen? Okay, great. Then have a good afternoon here from the Netherlands and good morning in Washington. I am really honored and very happy to have been invited to participate in this meeting and share with you our experience with implementing integrated diagnostics at my institution, Erasmus MC. These are my disclosures. I have been involved in the topic of integrated diagnostics through the International Society of Strategic Studies that I was honored to be president of in the past since more than 10 years. We actually organized a meeting together at that time with Hedy Richak on integrated diagnostics already in 2011 and published the proceedings in a paper in European Radiology that has been well cited since then. In the meanwhile, it seems that there is a widespread agreement about what is integrated diagnostics, and even ChatGPT is not misleading on its definition and strategic goals. So I would like to summarize my presentation by this quote. Whatever objective and strategic reasons are in favor of a change, a culture of resistance may be the main obstacle for implementation of an integrated approach. Let me give you a little bit of an overview of where I am coming from. The Netherlands has a strongly regulated national healthcare system with concentration of specialized care in the country's something like 75 hospitals, and with general practitioners as the gatekeepers of the system. Erasmus MC is the largest academic medical center situated in Rotterdam, the second largest city, with a very large harbor, the largest actually in Europe, and a highly multi-ethnic population. The clinical, teaching, and research activities are organized in divisions or teams, as we call them in Rotterdam, out of which the team Diagnostics and Advise is one of the largest, comprising almost all diagnostic departments and the pharmacy. Although most of the departments don't have much in overlap, the clearly identified common denominator and the strongly advocated common wish of the department's leaderships was the implementation of integrated diagnostics. This was obviously facilitated by the structures of which I happened to be the chair of the team Diagnostics and Advise over the past approximately 10 years. So what most of the department heads envisioned to achieve was a transition from a stepwise approach in the diagnostic pathways to an integrated concept in which requests and materials are sent to a front office, a number of tests are performed in the back office facilities of the respective departments, producing an integrated and comprehensive, hopefully final result, not needing any additional diagnostic steps. What we intended us to do is to provide a unified and final diagnostic input at the numerous multidisciplinary conferences and tumor boards. Initially, we thought, however, that the organizational structures or the management of the hospital and the lack of IT support would be the main barriers for the implementation. Therefore, we first conducted a survey among the relevant stakeholders of this project. And contrary to our expectations, the first two, the hospital leadership and the IT solution vendors, were easiest to be convinced. The main resistance, however, came from the side of the physicians. We asked the pathologists, and they were concerned about digitization and becoming a commodity. Radiologists were reluctant to take on board any additional responsibilities, given their anyhow high workload. And the referring clinicians were afraid of losing control and not being in the driver's seat anymore. So our first attempt was the implementation of a defined number of complex diseases, the implementation of integrated diagnostics in these diseases, in which we thought that an integration of the diagnostic steps would be of particular benefit for the patients and for the system. However, referring physicians were arguing that there would be no need for such an approach, given the fact that there are many clinical guidelines and they are following them, and therefore there is no need for additional integration. So we asked ourselves whether that is indeed what they do. We defined a few other clinical topics and looked whether they are indeed following the rules. So let me give you just an example of the adrenal and incidentalomas. We studied retrospectively something like 600 cases and looked whether one of those multiple clinical guidelines that are out there in the US, in Europe, and even locally, like this last one, were followed by the clinicians. But it turned out that the combined imaging and biochemical tests as required by the own Erasmus MC guidelines were followed in less than 15% of the cases. And this was similarly true for all the other diseases that we were looking to. So we couldn't really convince with these relatively clear arguments, we couldn't convince the clinicians that integrated diagnostics would be the way to go forward. So therefore, our second attempt was to look into some of a few pilot studies in which we try to demonstrate the benefit of our approach by solving discrepancies between radiology and pathology already prior to a multidisciplinary tumor board. We had a dedicated setup where radiologists and pathologists were asked to reconcile their discrepant findings in patients suspected of having, for instance, lung cancer. While initially there was agreement in less than 3/4 of the cases, the joint reading of images and of the specimens led to solving an additional almost 20% of cases, with only 7 cases remaining unsolved and requiring additional tests. However, the resistance from referring physicians remained unchanged. So our conclusion was that a successful implementation of integrated diagnostics needs some critical ingredients. Moving from sequential orders to the development of order sets indicating the combination of most appropriate tests and giving a comprehensive final diagnosis. For this purpose, we developed a homemade order management system generating order sets and defining all types of materials needed for performing those tests. The second ingredient was the development of structured, integrated reports delivering the combined and matched results. That's where we are now, and we realize that we are still not there. We hope that a further integration of clinical and omics data, as shown in previous presentations, allowing to provide some degrees of predictive analytics, will further facilitate acceptance of our integrated diagnostics approach in future. But for the time being, we have to accept that culture not only eats strategy for breakfast, but also any tactical approach for lunch and any other attempt for dinner. It is sad, but that is the reality, at least in our environment. So thank you very much for your attention, and I hope to be able to participate in the further discussion. Thank you.